Hello friends, my name is Dr. Saf and today in this video we are going to discuss hepatic dysfunction in critical care in critical illness, and which I found a very interesting topic to discuss because I am sure you all as intensivists are dealing with this issue in your day-to-day ICU practice. Hepatic dysfunction or ICU jaundice is a frequent finding in critical ill patients, and the liver plays a key role in the synthesis of proteins, detoxification of toxins, and drug biotransformation, and also the metabolism of nutrients. In patients with critical illness, hepatic functions are affected by various insults such as hypoxia, sepsis, medications, etc. And once liver functions are grossly deranged, the risk of systemic complications such as coagulopathy, encephalopathy, acute kidney injury, all these complications increases exponentially. Unfortunately, less attention has been paid to this issue because liver dysfunction is less immediately life-threatening compared to respiratory, renal, and cardiac failure. Okay, so that is why it is often ignored in ICU. Nevertheless, we should know what are the various definitions which are related to hepatic issues in critical illness. So, liver injury. So, liver injury is an elevation in the serum concentrations of routinely measured hepatic enzymes, including transaminases or aminotransferases or gamma glutamyl transpeptidase. Liver dysfunction or hepatic dysfunction is the derangement of synthetic or excretory pathways leading to rise in INR and rise in bilirubin. So that is your liver dysfunction. Okay. Whereas liver failure designates the liver injury that results in the life-threatening hepatic synthetic defect and brain dysfunction. So basically, coagulopathy, that is synthetic defect in the prothrombin, the coagulation factor, and encephalopathy, that is the brain dysfunction. So these two things have to be there to define the liver failure. Okay, and apart from that, there is also high incidence of acute kidney injury in liver failure. There are two types of liver injury. Okay, so they are fundamentally different from each other. So in hepatocellular injury, there is elevation in the serum aminotransferases, or otherwise known as transaminitis. So hepatocellular injury is otherwise known as transaminitis. Whereas other type of liver injury could be cholestatic injury, which is associated with elevation in ALP, that is alkaline phosphatase, and GGT, that is gamma glutamyl transpeptidase, with moderate or normal elevation of serum aminotransferases. So that is your cholestatic injury. So these two subtypes of liver injury you should know. Okay, so that is your cholestatic injury. Now, what are the most common causes of hepatocellular injury in ICU? So in ICU setting, the most common causes of hepatocellular injuries are hypoxia. Okay, that is called hypoxic hepatitis or ischemic hepatitis. Then another cause is the congestive hepatopathy. Okay, due to issues in the heart and volume overload. And then there is common problem, that is septic shock, where there is a vasodilated state and leading to alterations in the microvasculature of hepatic vascular system. And then there is also a chance of drugs, because in ICU we use a lot of drugs. So drugs, direct effect or interactions between drug can damage the liver cells. So that is important to know. Now, why AST and ALT are raised during hepatocellular injury? That is a common question anybody may ask, anybody may be intrigued, may be very curious to know. So the normal level of ALT is usually within 55 units, 50 to 55 units per liter, whereas AST is usually less than 50. So both are basically less than 50. During liver injury, hepatocellular permeability is increased. Okay, there is a leaky hepatocellular membranes, and that is why all the AST ALT are leaked from intercellular space to the extra cellular space or intravascular space, that is plasma, leading to massive rise in the AST and ALT, especially in cases of ischemia. Now, indeed, AST is not specific to liver. because it is produced by various tissues such as heart, muscles, lungs, brain, pancreas. Okay, so especially in ICU patients where there is a altered tissue perfusion, so any cell can release AST. So AST is not at all specific to liver alone. That is the most important fundamental thing you must know. That you should not look at the AST when you are looking at the liver function test. AST, however, is a very good marker of cardiac injury. Okay, that helps in prognostication of cardiovascular risk. It is also a marker of pancreatitis. Conversely, ALT is expressed mainly in the liver, so that is good. Normal serum ALT would exclude primary liver injury. So ALT is specifically produced by liver cells, and there is one exception that in alcoholic liver disease, in patients who are taking alcohol, the concentration of ALT may be normal or even low. Okay, and there is a ratio which is called AST-ALT ratio, which is usually less than one. In otherwise, in alcoholic, it will be more than one because in alcoholic, there is a deficiency of vitamin B6, that is pyridoxine, and the pyridoxine is necessary to synthesize the ALT. So basically, ALT is not formed because vitamin B6 is deficient in alcoholic, and that is the reason they have normal or low ALT compared to AST. So that is why the ratio is more than one. That is very, very important concept, very important fact. Now, okay. So now the question is, what is the ischemic hepatitis and how common it is? So let's understand this first. So about 5 to 10% of ICU patients develop ischemic hepatitis, which is also known as hypoxic liver injury or HLI or shock liver. It is a diffuse hepatocellular necrosis caused by hypoxia or hypoperfusion, resulting in the massive rise in aminotransferase levels in about thousands. Of note, ischemic hypoxia of the liver can be caused by increased venous pressure as well as decreased arterial pressure. Patients with unrecognized pre-existing liver disease might also be susceptible to hypoxic injury. Now, what is typical histopathological finding in hypoxic liver injury that you know that you must have read in your pathology book? So, typical histopathological finding in patients with HLI is the centrilobular liver cell necrosis. Okay. However, we do not need a liver biopsy to confirm this hypoxic hepatitis. That is a purely clinical diagnosis. But biopsy is never considered in ICU patient due to risk of bleeding. Okay, so this is a clinical diagnosis only. HLI usually characterized by three clinical cornerstone: an acute setting of cardiac or circulatory or respiratory failure, so there should be acute setting, a sharp but transient rise about more than 20 times of upper normal limit of aminotransferases, okay, an exclusion of other potential causes of liver injury or increased aminotransferase levels such as viral hepatitis or drug-induced hepatitis or autoimmune hepatitis. Okay, so other causes of hepatitis should be ruled out. Then only you can be sure about the ischemic hepatitis. So these three important clinical cornerstones should be fulfilled before you designate a patient that patient is having hypoxic liver injury. Now, what is critical illness cholestatic liver injury? How common it is, and what are the main contributory factors in ICU? So that you must know. So critical illness cholestatic injury is more common than hepatocellular injury because it can occur in up to 20% of ICU patients, and there are various reasons for that. But the most common cause of cholestatic liver injury is the impaired bile formation. Okay, so that is very important, and it could be obstructive or non-obstructive. Now in ICU, major causes of cholestatic jaundice or cholestasis include insults leading to hepatocellular injury, that is ischemic cholestasis. Okay, so that is your pathophysiology. So the first is the ischemic cholestasis or hypoxia that can lead to cholestasis. Second common cause is the drug sepsis. Sorry, sepsis. Sepsis is also important cause of cholestasis because it alters the microvascular uh, what called microvascular pattern or microvascular um, flow in the liver. Okay, so that is important. The sepsis. We will talk about that more in subsequent slide. And also hepatotoxic drugs. Okay, so that is also a very important. And when we are talking about drug, then we should not forget the parenteral nutrition. So these are the common ones, and also the blood transfusions overload. Okay, that is also one more cause. And when patient is on ventilator, then even positive end expiratory pressure, that is PEEP, or intermittent positive pressure. So any excessive pressure on the ventilator can result in hypoxic liver injury or cholestatic liver injury. Okay. Now the underlying mechanism includes the hepatocellular injury leading to decreased canalicular transport and decreased clearance of conjugated bilirubin. So that is the main pathophysiology of cholestasis. There are functional alterations at the hepatocellular level, like increased intestinal permeability. As a complication of sepsis, it can lead to endotoxin translocation from the intestinal lumen to the portal circulation, and then these endotoxin activate the Kupffer cells, which in turn secrete the pro-inflammatory cytokines like TNF alpha and IL-6 and nitric oxide, and these inflammatory processes alter the microvasculature and alter the flow of bile. Okay, so that is how the sepsis can result in the cholestasis. In addition, hepatic microvascular impairment caused by microthrombi formation aggravates the cellular dysfunction and in turn augment the cholestasis. So in few cases, increased bilirubin load also can cause this. Okay, like excessive hemolysis, which is caused by incompatible blood transfusion, or drugs which can result in increased bilirubin load, can lead to cholestatic pattern. Now, how will you diagnose? So diagnosis is important. So the diagnosis of cholestatic liver injury is based on markers. So ALP, alkaline phosphatase, is the first and foremost marker which is usually done, and it is a sensitive indicator of cholestasis. It is basically localized in the hepatocytes and cholangiocytes, and usually increased in secondary to intrahepatic or extrahepatic biliary obstruction. Then you can have a GGT, okay, that is gamma glutamyl transpeptidase. That levels are reported to be increased by up to 12 folds in obstructive liver disease compared to ALP. So GGT is more sensitive than ALP for the cholestasis. Okay, conjugated bilirubin is also raised, and its elevation indicates that enzymatic function is intact, but there is a failure of excretory function of liver. So that is a marker of excretory capacity of the liver. Okay, so these three important markers of cholestatic liver injury are important to understand, but you have to sometimes perform the hepatobiliary ultrasound, in which you would see the intrahepatic or extrahepatic biliary obstruction. So that is your anatomical diagnosis, and sometimes you may have to do ERCP, MRCP, etc. to find out better, to delineate the cholestatic liver injury. Now, the risk of hepatotoxicity in critically ill patients is increased because of the number of pharmacological agents we use. So DILI, that is called drug-induced liver injury, is initiated by direct hepatotoxic effects of drug or reactive metabolite of drug. And in some cases, it may be an immunological injury to some specific medications which can result in hepatic dysfunction. You must remember such a list of drugs with the help of clinical pharmacist, which will be useful for you to identify such agents, hepatotoxic drugs, which you could remove. And it is very important to review such drugs on a daily basis in ICU. For example, lipid lowering agents such as rosuvastatin or amiodarone used in various types of cardiac arrhythmia can cause liver dysfunction. Even macrolides such as erythromycin. Few of ICU patients may be on parenteral nutrition, and we should be careful about the liver injuries, so that we will discuss in the next slide. So the parenteral nutrition induced hepatotoxicity is incompletely understood phenomena. The etiology is not very clear, but they say that it is related to hepatic bile acid transport alterations, and that causes modification of gene expression involved in the apoptotic pathway, leading to alterations in detoxification process. In a prospective study done in 3,000 critically ill patients, Grau et al. found that acute hepatotoxicity occurred more frequently in patients receiving parenteral nutrition than in those receiving enteral nutrition. So there was a 30% or you can say 15% higher incidence in patients who were receiving parenteral nutrition. Another observation which this study gives you is that the daily caloric intake more than 25 kilocalorie per kg appears to be important, one of the most important factors predictive of parenteral nutrition associated hepatotoxicity, and that is the reason you must be careful about the calories. So the hypocaloric diet is better than hypercaloric in patients who are critically ill. Okay, so that is very important. Now, what are the therapeutic options? Currently, research looking into the treatment options in critically ill patients with cholestasis or HILI is lacking. First thing which we all should be able to do is to eliminate the underlying condition that has caused liver dysfunction. For example, treating the sepsis or maintaining mean arterial pressure more than 65 millimeter of mercury or avoiding hypoxia are few of these strategies, and avoiding the hepatotoxic drugs and keeping the patient on enteral nutrition rather than parenteral nutrition, and avoiding the unnecessary transfusions. Now, there is a study which looked into the positive inotropic substances like dobutamine, which may be helpful to improve the cardiac output and improve the hepatic blood flow. So that has been discovered in a recent paper. Okay, that is a controlled trial, clinical trial, which looked into the impact of administration of dobutamine on the hepatic injury in patients who underwent liver dissection, and they found that there was improved hepatic perfusion and oxygenation in cirrhotic patients who received inotropic agent like dobutamine. Another important factor is controlling the excessive glycemia. So in extreme cholestasis, maintaining a strict glycemia using intensive insulin therapy significantly reduces the rate of cholestatic liver dysfunction. Mesoten, that is, this is a paper, that's the clinical trial. They proposed that intensive insulin therapy can reduce the cholestasis and biliary sludge in the prolonged critical illness. Okay, so that's important fact. It is still under research, in research actually, and you may also conduct studies on this and find more and explore more in critical patients if you are working in teaching institute. So that's all for today. Thank you for your attention. See you later and keep going and ask questions. Bye bye.